In my first video, I gave an overall view of how my wife suffered a massive stroke due to an undiagnosed heart tumour, an event which was entirely preventable. In this second part, I would like to describe the 11 medical errors which led to her heart tumour remaining undiagnosed. My reference source for this video, and the other two of course, is my 2017 book A Life by Misadventure, which is available from Amazon. So the first mistake made by doctors was that they diagnosed Vivian's vasculitis purely on the clinical appearance of the lesions. Now, if you check the medical literature, you will find that this was undoubtedly bad practice. Probably the best scientific paper on this topic is Diagnostic Approach to Patients with Suspected Vasculitis by consultant rheumatologist Ernest Suresh. Dr. Suresh and others have stressed that the diagnosis of vasculitis should be made from a combination of the following: a history from the patient, clinical examination of the lesions, general examination of the patient, and most importantly, the results of special investigations, which might include skin biopsy, blood and urine tests, chest x-ray, pulmonary and renal function tests, and other special investigations, possibly including an echocardiogram, CT scan, and MRI scan. Dr. Suresh has also emphasised that investigation should start by excluding any conditions which can mimic vasculitis, such as atrial myxoma. When Vivian had her first attack of vasculitis in 2009, the only investigation that was carried out by the GPs was an electrocardiogram, a recording of the electrical activity of the heart. It cannot detect a myxoma, and I have no idea why the GPs ordered it. The second error was that the GP then treated this alleged vasculitis with high-dose oral corticosteroids. Now, that is not good practice. The only occasion vasculitis should be treated immediately with steroids would be in a case of acute temporal arteritis, also known as giant cell arteritis. And this is a condition I saw many times in ophthalmology. It presents with pain around the temporal artery, sort of around about there. If not treated immediately with steroids, the patient can lose vision in one eye. Even so, a blood sample should be taken before treatment starts, with the most important test being something called the ESR, erythrocyte sedimentation rate, which indicates inflammation in the body. Even so, if there's any doubt about the diagnosis, a biopsy of the temporal artery should be carried out. It should be noted that Vivian had no blood tests carried out until 2010. The third error was that a skin biopsy of the lesions was never done. On 6 May 2010, the dermatologist, who I will call Dr. Brown, that's not his real name by the way, saw Vivian and noted that a recent attack of vasculitis in her hand was settling down. He therefore decided not to carry out a biopsy. However, I have learned that even a biopsy of a fading or faded suspected vasculitis lesion can still yield useful results. In a true vasculitis, white blood cells can be seen under the microscope, whereas in a pseudo-vasculitis, actual particles of myxoma can be seen in the tissue sample, even after the rash is cleared. So if a biopsy had been carried out on 6 May 2010, I should say, the dermatologist would have had the correct diagnosis more than a year before Vivian's stroke. The fourth error was continuing with high-dose steroids when the diagnosis was unclear. This resulted in myxoma symptoms being attributed to the steroid. Vivian was off sick in the autumn of 2010, and this was entirely due to steroid side effects, including insomnia. The fifth error was the decision by the rheumatologist, who I will call Dr. Green, to change Vivian's medication to azathioprine. This is a very dangerous drug, similar to anti-cancer medication, and in my opinion should never have been prescribed since the diagnosis was unclear. It made Vivian sick, and many of the myxoma symptoms she suffered over the next few months were wrongly attributed to the azathioprine. Thus, the azathioprine masked the true illness, just as the corticosteroids had. The sixth error involved the rheumatologist placing too much emphasis on Vivian's cervical ribs. To explain further, Dr. Green ordered a chest x-ray, and this showed the presence of cervical ribs. These are a common anomaly in which there is an extra pair of ribs protruding from the cervical vertebrae. Often they cause no problems, but they can sometimes press on nerves and blood vessels and thus affect the circulation in the hands. However, Vivian had lesions in her hands and her feet. Cervical ribs cannot cause problems with the feet, so they were a red herring. Now, the seventh error was the rheumatologist's failure to consider the possibility that Vivian's skin lesions were caused by emboli, and the related failure to order an echocardiogram. I should add at this point that there are pathologies other than atrial which can cause emboli and which also require an echocardiogram for diagnosis. For example, endocarditis, an inflammation of the inner lining of the heart, can cause emboli, and the clinical picture can be identical to the pseudovasculitis caused by myxoma. Another investigation required in suspected endocarditis is blood cultures. Vivian never had blood cultures. Also, an echocardiogram is useful in vasculitis cases because it can show how the vasculitis is affecting the heart. So there were actually a number of reasons why an echocardiogram should have been carried out. The eighth error was the misdiagnosis of embolic episodes. I'm going to give you just a couple of examples. There are actually more in my book. On 4th September 2009, Vivian developed a swollen red big toe. I thought it might be gout. A GP registrar saw Vivian and also thought it was gout, but he didn't order any investigations. Gout is caused by a raised level of uric acid in the blood. If the doctor had ordered a full blood count and used these, it would have included a measurement of the blood uric acid level. And the fact that it was normal should have raised suspicions that this was something other than gout. Another thing that should have raised doubts was that Vivian was not in pain. And the gout, yet, is supposed to be one of the most painful conditions known to man. So if Vivian really had gout, she would have been in agony. So I believe this was not gout, but an embolus affecting the toe. I have another example. On 30th May 2010, Vivian had sudden onset severe dizziness. She felt the world spinning round and she screamed, "I'm dying, I'm dying." Now I thought she might have acute viral labyrinthitis and dialed NHS 24. An emergency GP saw her and also thought it was labyrinthitis and gave her Stemetil. However, her symptoms vanished within a few hours. Acute viral labyrinthitis is supposed to last between 1 and 6 weeks. So I think this was actually a transient ischemic attack, a TIA, caused by an embolus from the myxoma. TIA and strokes can sometimes present with acute onset dizziness. So between August 2009 and May 2011, Vivian had 20 embolic episodes, all of which were wrongly diagnosed, except for the last one, which caused her stroke. The 9th error was a failure to order enough investigations. I've already mentioned Dr. Ernest Suresh's paper, in which he mentions all the investigations that should be carried out in cases of vasculitis and suspected vasculitis. Vivian had all the suggested blood tests, but in my opinion, she should also have had an echocardiogram, a CT scan, an MRI scan, pulmonary and renal function tests, and a creatinine clearance test. An MRI scan and CT scan would also have shown the presence of the myxoma. The British Society of Rheumatology has produced guidelines on the investigation of ANCAT-associated vasculitis, which includes all the aforementioned investigations. The 10th mistake was that the GPs failed to recognise that Vivian had suffered a small stroke. In late April 2011, Vivian reported some difficulty doing handwriting. On 3rd May, she saw a GP who found nothing wrong in clinical examination. She was seen by another GP on 18th May after reporting no improvement. The GP didn't know what was causing the symptoms and did nothing. He suggested it might be due to the cervical ribs. Again, if Dr. Green had not flagged up the cervical ribs some months before, he might have not come to that conclusion. The GP also said that if there was no improvement in 2 weeks, he would refer Vivian to a neurologist. Just 2 days later, Vivian had her stroke. With the benefit of hindsight, Vivian's hand symptoms must have been caused by a small stroke. However, I feel that by this point, Vivian was running out of time. The window of opportunity to prevent her stroke probably closed some weeks earlier. So to summarise, Vivian's investigation was carried out by doctors who made multiple mistakes. Any investigation that was carried out was too little and too late. As one consultant friend said to me, the investigation was very poor. Dr. Green failed to come to a diagnosis, and the reason he didn't come to a diagnosis was that he didn't order sufficient investigations to enable him to make a diagnosis. In short, the NHS investigation was a tragedy of errors. Thank you for watching, and in part 3 out soon, I will be talking about what happened with our legal case. Stay tuned.